Hello everyone, I am Afreen and welcome to today's lecture. Today my topic is going to be about cardiovascular diseases. My topic will be covering the following 8 major objectives, which are concept of cardiovascular disease, epidemiology of cardiovascular disease, major cardiovascular conditions, change in epidemiology, common symptoms of cardiovascular disease, connection between mental health disorders and heart disease, major risk factors of cardiovascular diseases, interventions for different cardiovascular diseases, and cost effectiveness of interventions. So, let us start with what cardiovascular disease is. The leading cause of death globally is cardiovascular disease. A wide range of conditions are included under the umbrella term of cardiovascular disease, including illnesses affecting the cardiac muscle and the vascular system that supplies the heart, brain, and other essential organs. This topic examines the epidemiological transition that led to cardiovascular disease becoming the largest cause of death worldwide, evaluates the state of the transition by region, and identifies regional variations in the burden of cardiovascular disease. It also examines the cost effectiveness of various therapies targeted at the most important causes of cardiovascular disease, morbidity, and mortality. Now, we'll discuss the epidemiology of cardiovascular disease. Cardiovascular disease caused less than 10% of all deaths globally before the turn of the 20th century, but by 2001, that percentage had risen to 30%. In low and middle income nations, cardiovascular disease deaths account for almost 80% of the deaths worldwide. By 2020, Murray and Lopez anticipated that cardiovascular disease will overtake all other causes of mortality and disability worldwide, largely due to its rise in low and middle income nations. As in the developed world, since the mid-1900s, cardiovascular disease has risen to the top spot as the major cause of mortality in the developing world by 2001. Around 50% of all deaths occur in high-income countries, while 28% of deaths do so in low and middle-income countries. Injuries, respiratory infections, nutritional inadequacies, and HIV/AIDS still jointly account for the majority of fatalities in some locations, but even there, cardiovascular disease is becoming a major cause of mortality. Now we'll discuss another objective of today's lecture, which is major cardiovascular conditions, and these are ischemic heart disease, stroke, congestive heart failure, rheumatic heart disease. Since they share many of the same risk factors and cause at least 80% of the burden of cardiovascular disease across all income regions, similar therapies are necessary. Rheumatic heart disease, a fourth manifestation that accounts for 3% of all disability-adjusted life years lost due to cardiovascular disease, does not significantly add to the overall global burden of heart disease in developing countries, so is therefore not the focus. Because of the scope of this volume, the regional rather than the global nature of some inflammatory diseases like Chagas disease and the congenital abnormalities or genetically based cardiomyopathies for which there are still few preventative and therapeutic options. Let us discuss major cardiovascular conditions one by one. Starting with the ischemic heart disease. Ischemic heart disease is one of the major causes of illness burden in underdeveloped countries and the leading cause of death in wealthy nations. And acute myocardial infarction and angina are the two main symptoms of ischemic heart disease. Ischemic heart disease caused 7.3 million fatalities and 58 million disability-adjusted life years lost globally in 2001. 75% of worldwide fatalities and 82% of all disability-adjusted life years caused by ischemic heart disease happened in low and middle-income nations. Ischemic heart disease is characterized by pain called angina. It is brought on by atherosclerosis, which causes one or more coronary arteries to become stenosed, which is partially blocked. A death rate of no more than 2% occurs annually in patients with chronic stable angina. Acute myocardial infarction occurs when a major coronary artery is completely blocked, depriving the heart muscle of oxygen and nutrition, causing necrosis. Acute myocardial infarction is typically identified by abnormalities in the ECG, high levels of blood enzymes such as troponin T or I and creatine, phosphokinase, and angina-like chest discomfort. Even with the best medical care, the 30-day mortality rate after an acute myocardial infarction is high. It is around 33%, with 50% of deaths taking place before the patient even arrives at the hospital. Mortality is around 7% even in a hospital with a coronary care unit and access to advanced treatment options. The death rate is closer to 30% in a hospital without these amenities or treatments. Despite a significant drop in mortality among patients who have recovered from an acute myocardial infarction, almost 4% of those who survive the initial hospitalization pass away the year after the incident. Another cardiovascular condition is stroke, whereby an obstruction in a blood vessel, that is ischemic stroke or blood vessel rupture, results in a stroke when blood flow to a portion of the brain is disrupted, which is also known as hemorrhagic stroke. Atrial fibrillation is a significant risk factor for stroke, as are many of the same risk factors that contribute to ischemic heart disease. Non-valvular atrial fibrillation increases the risk of stroke by 3 to 5% annually and is responsible for 50% of thromboembolic strokes. Next cardiovascular condition is congestive heart failure. Many cardiac disorders progress to congestive heart failure at some point. Fatigue, fluid retention, and shortened lifespan are symptoms caused by anomalies in cardiac function and neurohormonal control. Ischemic heart disease and hypertension-related heart disease are the most frequent etiologies of congestive heart failure. Congestive heart failure is brought on by pathological processes that affect the heart. In comparison to people with normotension, hypertensive men and women had a twofold and threefold increased risk of having congestive heart failure, respectively. Acute myocardial infarction recipients have a congestive heart failure rate that is 5 times higher than non-recipients. The prognosis for people with established congestive heart failure is typically dismal and worse than for people with the majority of cancers or AIDS, with a mortality rate of up to 40% after 1 year and a mortality rate of between 26 and 75% after 5 years. The cost of congestive heart failure is significant and is rising globally. Around 2 to 3% of the developed world is affected, with an annual incidence rate of 0.1 to 0.2%. However, as people age, congestive heart failure incidence and prevalence rapidly increase. For individuals over 65, the prevalence is 27 per thousand people, while it is only 0.7 per thousand for those under 50. Men are more likely to develop congestive heart failure, and the incidence and death vary significantly by gender and socioeconomic position. Congestive heart failure is responsible for 53,000 fatalities annually in the United States and contributes to another 213,000. From 1979 to 2001, the death rate in the country attributable to congestive heart failure increased by 155%. In 1 million hospital admissions, congestive heart failure is the initial diagnosis. Another one is rheumatic heart disease, the result of a group A hemolytic streptococci-induced acute rheumatic fever or a poorly adapted immunological response is rheumatic heart disease. The connective tissue is affected, particularly the joints and the heart valves. Valvular stenosis, post-valvulitis regurgitation, or both are the most significant consequences. Rheumatic heart disease is also a risk factor for infective endocarditis, a condition that primarily affects young adults who are male. Rheumatic heart disease is thought to be responsible for 338,000 deaths annually worldwide, with the majority occurring in Southeast Asia and the Western Pacific, according to estimates from 2001. Rheumatic heart disease affects over 12 million people in poor nations, the majority of whom are children. According to research of developing nations by Stair and colleagues from 2002, rheumatic heart disease prevalence in children ranges from 0.7 to 14 per thousand, with Asia having the greatest rates. According to Stair and others, rheumatic heart disease and acute rheumatic fever account for over 10% of sudden cardiac death in children in developing nations. Acute rheumatic fever was a major contributor to cardiovascular issues among school children in developed nations up until the 1950s, and although it is now much less common, outbreaks still happen, indicating that neither antibiotics nor other public health measures have been completely successful in controlling acute rheumatic fever. Now, let me bring your attention to another objective of my topic, which is the change in epidemiology. The causes of illness and death have undergone a significant shift during the last 2 centuries as a result of the industrial and technological revolutions. Prior to 1900, infectious diseases and malnutrition were the leading causes of death, but due in large part to advances in nutrition and public health initiatives, cardiovascular disease and cancer have steadily replaced them in the majority of high-income countries. Mortality rates from cardiovascular disease are rising as advancements continue to span to developing nations. The epidemiological transition, also known as the social transition, the economic transition, and the demographic transition, are all strongly associated with this development. The epidemiological transition is divided into 3 major ages by Omran, who offers a great model of it. These ages are marked by plague and starvation, receding pandemics, and degenerative and human-caused diseases. Delayed degenerative disorders are added as a 4th stage by Olshansky and Old. The epidemiology was prevalent in the majority of high-income nations during the 1970s and 1980s, but the rate of reduction has subsequently slowed. 300 million people are clinically obese and overweight. Even more alarming is rising rates of childhood obesity that have significantly raised diabetes and hypertension rates. If these patterns persist, age-adjusted cardiovascular disease mortality rates may rise in high-income nations. Let us now discuss the common symptoms of cardiovascular disease. Specifically, symptoms of heart attacks and strokes. Often there are no symptoms of the underlying disease of blood vessels. Heart attack or stroke may be the first sign of underlying disease, and the symptoms include pain or discomfort in the center of the chest, pain or discomfort in the arms, the left shoulder, elbows, jaw, or back. In addition, the person may experience difficulty in breathing or shortness of breath, nausea or vomiting, lightheadedness or faintness, a cold sweat, and turning pale. Women are more likely than men to have shortness of breath, nausea, vomiting, and jaw pain. The most common symptoms of a stroke are sudden weakness of the face, arm, or leg, most often on one side of the body. Other symptoms include sudden onset of numbness of the face, arm or leg, especially on one side of the body, confusion, difficulty speaking or understanding speech, difficulty seeing with one or both eyes, difficulty walking, dizziness or loss of balance or coordination, severe headache with no known cause, and fainting or unconsciousness. Moving forward to another objective of my topic, which is connection between mental health disorders and heart disease. A large and growing body of research shows that mental health is associated with risk factors for heart disease before a diagnosis of the mental disorder and during treatment. These effects can arise both directly through biological pathways and indirectly through risky health behaviors. People experiencing depression, anxiety, stress, and even post-traumatic stress disorder over a long period of time may experience certain physiologic effects on the body, such as increased cardiac reactivity, for example, increased heart rate and blood pressure, reduced blood flow to the heart, and heightened levels of cortisol. Over time, these physiologic effects can lead to calcium buildup in the arteries, metabolic disease, and heart disease. Evidence shows that mental health disorders such as depression, anxiety, and post-traumatic stress disorder can develop after cardiac events, including heart failure, stroke, and heart attack. These disorders can be brought on after an acute heart disease event from factors including pain, fear of death or disability, and financial problems associated with the event. Some literature notes the impact of medicines used to treat mental health disorders on cardiometabolic disease risk. The use of some antipsychotic medications has been associated with obesity, insulin resistance, diabetes, heart attacks, atrial fibrillation, stroke, and death. Mental health disorders such as anxiety and depression may increase the chance of adopting behaviors such as smoking, inactive lifestyle, or failure to take prescribed medications. This is because people experiencing a mental health disorder may have fewer healthy coping strategies for stressful situations, making it difficult for them to make healthy lifestyle choices to reduce their risk for heart disease. Let us now talk about the risk factors associated with cardiovascular disease. Numerous risk factors must be present in order to increase one's chance of developing cardiovascular disease. The primary cardiovascular disease risk factors are smoking, high blood pressure, high blood sugar, lipid abnormalities, obesity, and inactivity. Variances in these well-known risk variables, temporal and regional distribution, are linked to regional and worldwide variations in cardiovascular disease rates. The majority of risk is related to lifestyle and behavioral habits, which may be altered despite the fact that some risk variables such as age, ethnicity, and gender are apparently immutable. Now let us move forward to the last objective of today's lecture, which is interventions for different cardiovascular diseases and cost effectiveness of interventions. One of the most researched and written about medical topics is still cardiovascular disease. As a result, there are numerous therapies with substantial evidence for lowering morbidity and death linked to cardiovascular disease. Following things come under this very objective. The first one is effectiveness of interventions by disease. It focuses on those therapies that are thought to have the greatest impact because they significantly reduce the number of cardiovascular disease events, are relatively inexpensive, or have a high prevalence or incidence of the conditions they are intended to treat. The absence of an intervention does not imply that it is not cost-effective. Rather, it simply means that either it had a less significant impact on the population as a whole or that it was unable to cover all relevant initiatives. Second one is acute myocardial infarction. Medical therapies that lower myocardial oxygen demand and prevent fatal arrhythmias, that is beta blockers, restore blood flow by preventing platelet aggregation, dissolve thrombi blocking arteries, or require an invasive procedure like cardiac catheterization and angioplasty, are all used to treat acute myocardial infarction. Both before and after an acute myocardial infarction, beta blockers are taken. Benefits continue for a minimum of 6 years and a maximum of 15 years following the initial acute myocardial infarction. In the second thrombolysis in myocardial infarction trial, beta blockers were found to be significantly more beneficial when taken within 2 hours after symptoms. The conventional treatments for reopening the artery in acute myocardial infarction, thrombolytic drugs and aspirin, have shown an additive impact in lowering mortality, with a benefit regardless of age, sex, blood pressure, heart rate, or previous history of acute myocardial infarction or diabetes. Third one is invasive interventions. An invasive procedure is one where purposeful or deliberate access to the body is gained via an incision, percutaneous puncture, where instrumentation is used in addition to the puncture needle, or instrumentation via a natural opening. According to Anti-Thrombotic Trialists Collaboration 2002, 2 years of treatment is recommended for people with vascular disease. The advantages of antiplatelet medications clearly exceed the hazards. Antiplatelet medications raise the risk of cerebral bleeding by over 25%, yet in absolute terms, there are only 1 or 2 brain bleeds per 1,000 patients treated annually. Additionally, the risk of significant extracranial bleeding, mostly gastrointestinal, increase by 60%, or 1 to 2 additional episodes per 1,000 patients annually. Aspirin is the most well-known and often used medication. However, there are other medications such as clopidogrel or ticlopidine with comparable effectiveness but much higher costs. Aspirin is effective in doses as low as 75 to 100 milligrams per day. One of the pillars of treating cardiovascular disease is lowering low-density lipoprotein cholesterol levels and raising high-density lipoprotein cholesterol levels. Researchers have hypothesized that unhealthy cholesterol levels are responsible over 2/3 of the world's cardiovascular risk. Although lowering total or low-density lipoprotein cholesterol has traditionally been the goal of lipid-lowering therapy, medical professionals are increasingly realizing the significance of raising high-density lipoprotein cholesterol and reducing triglyceride levels, particularly in high-risk individuals like those with diabetes or metabolic syndrome, as well as in ethnic populations like Southeast Asians. Recent research has shown that the association between cholesterol levels and vascular events is continuous and happens considerably earlier than previously thought. The clinical trials have consistently demonstrated a 25 to 30% reduction in the risk of cardiovascular morbidity and mortality. Furthermore, the evidence suggests that more aggressive reductions in cholesterol have higher benefits than mild or moderate reductions. Even patients with presumed normal blood pressure and prior vascular disease benefit from lowering blood pressure, confirming earlier evidence that individuals with a history of acute myocardial infarction who have lower blood pressure are less likely to have future vascular events. Furthermore, investigators have established mortality and morbidity benefits for several specific classes of drugs to reduce blood pressure in patients with vascular disease, namely beta blockers, calcium channel blockers, and angiotensin-converting enzyme inhibitors. In patients with a prior history of stroke or transient ischemic heart attack, occlusion of arteries supplying the brain, the long-term benefits of lowering blood pressure have been clearly established. Lowering blood pressure reduces the overall risk of future stroke by 28% and of the other vascular events and congestive heart failure by 26% in patients with a history of stroke disease irrespective of their hypertension status. The benefits are even more pronounced for individuals with a history of hemorrhagic stroke. Furthermore, beta blockers provide clear benefits in patients with chronic stable angina, where they provide symptom relief as well as reductions in vascular events. Angiotensin converting enzyme inhibitors have proved invaluable in preventing cardiovascular events and congestive heart disease in those with ischemic heart disease. The extent to which the benefits conferred by their use are caused by their ability to lower blood pressure or by their other properties such as cardiac remodeling and neurohormonal modulation is not clear. Long-term use of angiotensin converting enzyme inhibitors in those with a history of myocardial infarction and in other individuals at high risk of vascular disease reduces vascular mortality by 25% and other non-fatal events such as recurrent myocardial infarction, revascularization, hospitalization, progression or new onset of congestive heart disease and stroke. In those with asymptomatic or symptomatic left ventricular dysfunction after myocardial infarction, angiotensin converting enzyme inhibitors reduce the risk of a variety of vascular endpoints by 20 to 26%. Similarly, the use of angiotensin converting enzyme inhibitors, even in those with no evident left ventricular dysfunction, confers a 21% reduction in risk for major coronary events, 32% for stroke and 20 to 22% for composite vascular outcomes. Next is non-pharmacological interventions. Giving up smoking and making dietary changes are significant secondary cardiovascular disease preventive objectives. Cardiac rehabilitation, which includes exercise, benefits a variety of ischemic heart disease patients and cuts the risk of future vascular events by 15%. Exercise alone lowers vascular endpoints by 15% and vascular mortality by 24%. Trials for psychological therapies aimed at treating stress, depression, a lack of social support, and other issues have produced mixed results. Another one is interventions with congestive heart failure. The most often prescribed diuretics for congestive heart disease are loop and thiazide diuretics. Diuretics are the only medications that can effectively manage the fluid retention associated with congestive heart disease. Therefore, they provide symptom relief more quickly than any other congestive heart disease medicine. Researchers have found that angiotensin converting enzyme inhibitors cut risks for a range of endpoints by 25 to 33%, including mortality, hospitalization, major coronary events, symptoms getting worse, and the development of symptomatic left ventricular dysfunction. The benefit is given regardless of the cause of systolic failure, starts quickly after treatment begins, lasts for a long time, and is unrelated to age, sex, or baseline usage of other drugs. Additionally, the usage of angiotensin converting enzyme inhibitors has proven to be quite cost-effective in industrialized nations. Beta blockers enhance symptoms, lower hospitalization, and decline in cardiac function, and boost mortality. Even if the patient develops no symptoms, they should still be administered. At all phases of congestive heart disease, beta blockers are helpful and reduce the morbidity and mortality rates by 25 and 33%. The preventive effects of beta blockers are likely connected to their arrhythmic qualities because sudden cardiac death is the leading cause of death for individuals with congestive heart disease. Although it has no impact on vascular or overall mortality, digital ease reduces hospitalization rates in those with congestive heart disease. Its role in conventional treatment for congestive heart disease has declined because it too has a constrained therapeutic toxic window and needs careful monitoring. Next is interventions with rheumatic heart disease. Providing anti-streptococcal therapy, controlling clinical symptoms, and screening children are all part of the management of people with acute rheumatic fever. All acute rheumatic fever patients should have a 10-day course of penicillin in the acute stage, just as they would if they had a group A streptococcal infection. Anti-inflammatory drugs treat symptoms during acute rheumatic fever, but do not stop rheumatic heart disease from occurring. Penicillin or sulfadiazine is used as secondary prophylaxis to avoid colonization of the upper respiratory tract for the first 5 years and for life for patients with valvular heart disease. Non-compliance is common, occurring in up to 1/3 of patients. Surgery for valve replacement or valvuloplasty is part of tertiary treatment. And the last one is interventions with ischemic heart disease. In acute myocardial infarction, 4 incremental acute myocardial infarction therapy options are assessed and contrasted with a base case strategy of no treatment. Aspirin, and atenolol, aspirin, atenolol, and streptokinase and tissue plasminogen activator were the 4 therapeutic options. All patients receiving the medicines experienced a decreased relative chance of dying from acute myocardial infarction. Major bleeding and hemorrhagic strokes were at an elevated risk for those using the thrombolytics. 2 further sensitivity analyses were conducted to examine the use of streptokinase for patients over and under the age of 75 and for patients who get the intervention sooner or later than 6 hours following the beginning of symptoms because the effectiveness of streptokinase declines over time. Now, we will conclude this topic with the pitfalls and promises associated with cardiovascular disease. The burden of disease is shifting as a result of a global cardiovascular disease epidemic. Nowadays, developing nations experience twice as many cardiovascular disease deaths as developed ones. Conventional risk factors account for the great majority of cardiovascular disease. High blood pressure, high cholesterol, heavy alcohol and tobacco use, as well as dearth of fruits and vegetables are already among the leading causes of disease in sub-Saharan Africa. The entire impact of exposure to these risk factors won't be felt until later because of the temporal lag associated with cardiovascular disease risk factors, particularly in youngsters. More 13 to 15-year-olds are smoking than ever before, according to data from more than 100 nations, and studies show that childhood obesity rates are rising. Population-wide initiatives to eliminate risk factors today will result in savings later on in terms of medical and other direct costs, as well as indirectly in terms of better quality of life and economic output. That brings us to the end of the topic. Thanks for watching.